Hi, I'm Dr. Neurosurgery Greenberg, and we are continuing with the pituitary tumors. Today we're looking at Cushing Syndrome. So, what is the basis for chemical testing in Cushing Syndrome? Normally, a low dose dexamethasone suppresses ACTH release through negative feedback on hypothalamic pituitary axis, which reduces urine and serum corticosteroids. But in more than 98% of Cushing syndrome, what happens is that suppression occurs but at a much higher threshold. Renal tumors and most 85 to 90% cases of ectopic ACTH reduction, especially bronchial carcinoma, will not be suppressed whether you give low or high dose. It will not be suppressed at any dose. An ACTH response to CRH is exaggerated in Cushing syndrome. Dexamethasone does not interfere with the measurement of urinary and plasma cortisol and 17-hydroxycorticosteroids. So, what tests are used for hypercortisolism? These tests are used to determine if hypercortisolism, Cushing syndrome, is present or not. Whether hypercortisolism, Cushing syndrome is present or not, regardless of etiology. Usually, it is only needed if the screening of 24-hour urine-free cortisol is equivocal. The basis of these tests was already shown. So, if we are considering hypercortisolism, we have to check 24-hour urine-free cortisol. And if that comes equivocal, what do? So, first what you do is overnight low-dose dexamethasone suppression test. You give an overnight low-dose test, 1 milligram per oral at 11 p.m. and you draw serum cortisol next day at 8 a.m. If in the morning cortisol measured is less than 1.8 microgram per deciliter, Cushing syndrome is ruled out. There is no hypercortisolism. If cortisol level is 1.8 to 10 microgram, it is intermediate and you have to retest. If cortisol is more than 10 microgram per deciliter, then Cushing syndrome is probably present. But the problem is that false positives can occur because of pseudo-Cushing state, where ectopic CRH secretion produces hyperplasia of pituitary corticotrophs, which is clinically indistinguishable from pituitary ACTH producing tumors. Therefore, it requires further testing. And it can also be seen in alcoholics or patients on phenytoin or phenobarbital due to increased metabolism of dexamethasone caused by induced hepatic microsomal degradation. Then you do 2-day low dose test. If you did the test, if you did low dose cortisol dexamethasone suppression testing and it came equivocal, that is result was between 1.8 and 10, in that case you do give dexamethasone 0.5 milligram every 6 hours for 2 days starting at 6 a.m. and then you do 24-hour urine collections prior to test and on the second day of dexamethasone suppression administration. In the case of normal patients, urinary 17-hydroxycorticosteroids will be less than 4 milligram per 24 hours, but in patients with Cushing syndrome will have higher amounts. Then there is 11 pm salivary cortisol, which is the time of the usual cortisol nadir. Nadir means the lowest cortisol. So that's all, and we will continue in the next presentation. Thank you.